Very good evening, MRCP Part 1 aspirants. Today's the class is about neurology, which would be conducted by Dr. Varun Pushkarna. He's a senior consultant in internal medicine at FORTIS Escort Hospital, Amritsar. His area of interest is in rheumatology, hematology, and cardiology.
Thank you, Fatima. Good evening, doctors. So, we'll be taking up an introductory class on neurology today. So, basically, neurology is one of the biggest chunks in MRCP exam, be it part one, be it part two, and at least you will have at least one case in PACES exam also. So, it is a core branch to medicine, hence, it is very important. Let's start. So some questions will be asked from the clinical correlation of neuroanatomy. Others would be from neurophysiology, then neuropharmacology. So for the MRCP part one, you basically need to have the knowledge of allied systems like pharmacology, neuroanatomy, neurophysiology, neuropathology. So these things they matter in MRCP part one exam. So the first question that we are going to do today is basically from neuropharmacology. So regarding gabapentin, we know gabapentin basically is a GABA agonist, GABA receptor agonist. It is utilized in chronic pain syndromes. So regarding gabapentin, which of the following statements is true? Now, because these pharmacology questions, they can be asked in many forms, but usually the pharmacology questions, be it neuro, be it cardiac, be it any other system, nephrology even, they are usually asked in a true and false pattern. Why? Because from one question you can ask so many questions. It's obvious that one of the answers will be correct, but they will expose you to more options pertaining to the same topic. So similarly here, regarding gabapentin, which of the following statements is true? Side effects typically include visual field defects with long-term use. Therapy is best monitored through measuring plasma concentrations. It is a potent enzyme inducer, is of particular value as monotherapy in absence attacks, and requires dose adjustment in renal disease. So this is very important question. So which of the following is true? So it is a well-known fact that pregabalin and gabapentin, both of them, they have a renal excretion mode. So most of it is excreted in an unchanged form through the kidneys into the urine. So whenever the creatinine clearance is less than 60, the doses of these drugs, they have to be adjusted, or else sometimes they can have a lingering on effect even up to 5 to 6 times the half-life. I mean, 5 to 6 half-lives of the drug, they will remain inside the body. So side effects typically include visual field effects. No. So basically what happens is dizziness happens, blurring of vision can happen, uh, and ataxia can happen. That happens because of the sedation part of it. Therapy is best monitored through plasma concentrations. No. Gabapentin and pregabalin, they have a a very good volume of distribution. So hardly any drug it stays inside the plasma. It is a potent hepatic enzyme inducer. It is false. Is of particular value as monotherapy in absence attacks. See, in absence attacks, the drug of choice is different. So it is basically not gabapentin. So gabapentin, although it is a GABA agonist, but unlike other anticonvulsants like phenytoin and phenobarbital, it does not induce any liver enzyme. Visual effects, remember V for visual effects and V for vigabatrin. So you can remember this by the alphabet V. Visual disturbances rarely are associated with GABA. As of petit mal, I told you gabapentin is of no use. It is just used as an add-on therapy in people with partial and general seizures. Next question is about a 69-year-old lady presenting to the pain clinic with 1 year history of gradually increasing pain in her bilateral legs and weakness. Now, this, is a particular history which is also given in Guillain-Barré syndrome. So the problem here is gradually increasing pain in both legs. Along with that, there is weakness. So not only the weakness, but pain also is there. She doesn't have any other history apart from being 69 years of age. She has no alcoholic or smoking history. The knee reflexes are reduced and the fasting glucose is 116. So this basically they are hinting towards neuropathy. So painful neuropathy. Now neuropathy is of many types: tingling neuropathy, emaciating neuropathy, and then painful neuropathy. So this is painful neuropathy. So which of the following is the best next investigation to confirm the most plausible diagnosis? So once you see that a patient has peripheral neuropathy, which is of painful type, so you want to ascertain the cause for that neuropathy. So right here, because the fasting blood glucose levels have already been given as 116, which is much above the level that should be there. So we should be thinking of, subjecting this patient for uh, diagnosing diabetes. So one is chest X-ray, the other is oral glucose tolerance test, the third is cerebral spinal fluid examination, fourth is vitamin B12 and folate levels, fifth is MRI of the spine. Now here is the catch. As far as this patient is concerned, because you understand that they have neuropathy and that is a peripheral neuropathy, which does not have radiculopathy. So radiculopathy is a low backache which radiates down to the legs. So that in that case, you would want to get an MRI of the lumbar spine.
So
Just
vitamin B12 and folic acid we can test for peripheral.
See, why do you want to check folic acid levels? Folic acid levels, do they determine any kind of neuropathy?
Vitamin B12 causes neuropathy.
Yeah, vitamin B12, it will cause, but it will not cause a painful neuropathy. It is like walking on cotton wool. That is all. It is like, so it is a neuropathy of a different type. It's not painful neuropathy. Painful neuropathy is, usually considered as a part and a parcel of one diabetes. Second, you can see painful neuropathy in the ascending phase of Guillain-Barré also. So when the patient is developing it, the patient will have pain in the legs. Then a patient can have peripheral neuropathy with pain in certain conditions where neuropathy is also associated with myopathy. So right here, we would like to diagnose diabetes in this patient, or maybe want to rule out diabetes in this patient. Eventually, what would help in the diagnosis of this patient is going to be nerve conduction study. Because if you want to establish a diagnosis, the neurodiagnosis, right now the question is about what could be the underlying cause. That we would find out by subjecting the patient to an oral glucose tolerance test. But if you say that I want to make and establish a diagnosis of what kind of neuropathy, whether it is an axonal type or a non-axonal type neuropathy, then you will require a nerve conduction study. So yes, the diagnosis is diabetic amyotrophic neuropathy. The neuropathy word is missing here. So this is suggested by bilateral leg pain because it is painful, along with weakness and reduced knee reflexes. So the knee reflexes are also gone. So I'm telling you, it is almost similar to GBS. The only thing is the GBS has a very fast course of action and the patient becomes sick very early and, with involvement of bowel and urinary systems as well. So sphincter control is lost. So here we have a patient of neuropathy with impaired fasting glucose concentration. So oral glucose tolerance test will be helpful. Now in the elderly, diabetic amyotrophy is not uncommonly a presenting feature because they hardly eat anything. So they do not get all the symptoms of diabetes, but usually what you get is picture like this sometimes. The 8-year-old gentleman presents to the OPD with an 8-week history of lethargy. So the duration is mentioned, 8 weeks. 8 weeks means around 2 months of lethargy, neck pain, and weakness in the upper limbs and some problem with the gait. He describes occasional episodes of electrical sensation shooting down his spine on flexing the neck. Can you tell me what sign is this? When an electrical sensation runs down the spine of a patient? Because if you can pick up this, then the answer will also be in front of you.
Is it swirling?
It's Lermit sign. So the patient Lermit sign. So this is usually seen in multiple sclerosis and in cervical spondylosis also. So these are the conditions where you can have electrical sensation shooting down the spine and flexing the neck. He has a long history of lower back pain, primary generalized osteoarthritis. This is important. And vitiligo. He takes Voltaren regularly. He neither smokes nor alcohol. He is of Philippine origin and has been in United Kingdom for the past 9 years. He denies any recent history of foreign travel. He is afebrile. General physical examination is unremarkable except for vitiligo. Examination of cranial nerves 1 to 12 is also normal. There is no wasting of limbs, but there are few fasciculations in brachioradialis. Okay, so there are fasciculations in brachioradialis and biceps on the left. Tone is mildly increased. So this is kind of a UMN picture. Apart from the mild weakness of elbow, wrist, and finger flexion and extension more marked on the left, power is normal. There is inversion of the left supinator reflex and triceps. Jerks are reduced bilaterally. Sensation is mildly reduced in C5, C6 dermatomes. Basically, this is a compressive myelopathy, compressive cervical myelopathy. That is why both the motor and the sensory components are involved. Hemoglobin is 11.2, slightly anemic. Platelet count TLC normal, coagulation normal, ESR normal. So tuberculosis is out. Because of Filipino region, they are basically trying to confuse you by giving the Filipino connection so that you might start thinking about tuberculosis. But ESR is literally ruling out a spinal tuberculosis. CRP, which is 16.4, so there is something is wrong. Serum sodium, potassium, urea, creatinine, protein, albumin. So albumin is 39. So whatever the rest is globulin, that's okay. And serum calcium is normal, 2.21, normal. Phosphate, normal. Liver function test, normal. Chest X-ray, normal. C-spine X-ray, extensive osteophytes. So this patient has a history of osteoarthritis and extensive osteophytes in the C-spine. So what is the possible diagnosis?
Cervical myelopathy.
Wonderful. So it looks like cervical myelopathy. So let's see what are the answers. PMR, syringomyelia, degenerative cervical spondylosis, MND, multiple myeloma. So let's start with PMR. What are the factors against PMR? Normal ESR is against the diagnosis of PMR and presentation also. So there is in PMR there is a painful weakness of the proximal girdle. So ESR is elevated, and the patient is usually a female above 50 years of age along with sleep disturbances. Syringomyelia is basically a condition where syrinx or cyst is formed in the upper portion of the spinal cord where it is connecting with the brain. So it will not have symptoms like this. Degenerative cervical spondylosis, almost the answer, cervical myelopathy. MND, it doesn't look like a picture of MND, although fasciculations they have given, but sensory symptoms will not be there. Multiple myeloma with the normal ESR, with the normal calcium, and with the normal protein levels, the multiple myeloma diagnosis also does not. So the answer is C, and C is degenerative cervical spondylosis. So most common progressive disorder of cervical spinal spondylosis. So have you understood why others are not the answers? Because that is very important to rule out other diagnoses. Yes? Okay. So here is the basic what you want to know. Compression, stretching on or angulation of the cervical nerve roots causes radiculopathy. Compression, ischemia or recurring minor trauma of the cord results in myelopathy. The most common cause of myelopathy in adults is cervical spondylitic myelopathy. Patients present with signs and symptoms of cervical cord dysfunction with or without cervical nerve root injury. Therefore, a mixture of upper and lower motor neuron signs are there. These may or may not be accompanied by pain in the neck and or upper limb, orbits and temporal region. There is often cervical stiffness and poor balance in addition to this. There is a limited range of movement of cervical spine and poorly localized tenderness on examination. MND could be an important diagnosis, but you understand that sensory disturbance will not be seen in motor neuron disease. That is why it's called motor neuron disease, because there are no sensory symptoms. As far as polymyalgiarheumatica is concerned, it is an inflammatory disorder, and with a normal ESR, you should not be suspecting polymyalgiarheumatica. As far as syringomyelia is concerned, there is a syrinx or basically a cyst which is compressing on the corticospinal and the spinothalamic tract. Later, the anterior horn cells as it enlarges and expands. So again, motor symptoms are not there. So syringomyelia, the patient will have more of sensory symptoms. Sensory symptoms are the predominant features. Is that clear?
Sir, one doubt. It said that the risk of getting this condition is from horse riding, rugby, and flying. How can flying cause that when you're sitting in a plane?
Okay, so when we are flying and we are having this seat belt on, so basically the neck is the only portion of the body which can move freely. So in case of a jerky situation, when there is turbulence in the air, there are chances that the neck can suffer a whiplash injury. So this is more for the people who are sitting in front of the airplane, like the pilot himself. So they have this jerky movements of the neck. So imagine if somebody is sleeping and there is a turbulence in the air, then the jolts that we get, that they can give a C-spine injury. So cervical trauma can happen. Even the mildest of the traumas can lead to spinal compression. All you need is a slipping of one vertebra over the other and kinking the spinal cord. Is that clear?
Thank you, sir. Thank you.
Yeah. So it is more commonly seen in people who are on the pilot seat. So if you know the people who fly gliders, there is an extra, piece of belt for them, for those who fly the gliders, because in the glider the neck is literally, because they do saltings and everything. So there are chances the neck injury can happen. Next question, which one of the following features would be expected in a 45-year-old lady who is diagnosed with dystrophia myotonica? So dystrophia myotonica is a diagnosis which is a favorite of MRCP people. They keep asking it, and many times it has occurred in the past as well. So you need to be very, very well versed with the diagnosis dystrophia myotonica or myotonic dystrophy. So just as a passing remark, people with myotonic dystrophy, they usually have cataracts. And it's a congenital condition. So there are cataracts, there is frontal baldness, there is increased incidence of having diabetes, and of course there is myotonia and reduced reflexes. So preserved tendon reflexes are not there because the reflexes are reduced. Progressive external ophthalmoplegia. Actually, progressive external ophthalmoplegia is not there. Usually what you have is bilateral ptosis. So bilateral ptosis is there. Autosomal recessive inheritance, no. Myotonia dystrophica has autosomal dominant. Fasciculations would uh, predominate. Basically, it usually has a lot of weakness and there is increased tone, generalized tone increase is there. So myotonia is what we call. So there are no fasciculations, but there is myotonia. So what would be the answer? I told you autosomal recessive, it's not, it's autosomal dominant. Progressive external ophthalmoplegia, no. Basically, they just have ptosis. Preserved tendon reflexes false because tendon reflexes are lost. Fasciculations, no. Basically, there is increased tone. So cataract is the answer. So answer is cataract. So an autosomal dominant condition with variable penetrance. Dystrophia myotonica usually starts at the age of 20 to 30 years, begins with weakness and myotonia. So other features are cataract, ptosis, frontal baldness, gynecomastia, diabetes, and reduced reflexes with myotonia.